Lovely. I'd like to hand over to Dr. Rob Will. So Sophia, if you can hand Dr. the hosting rights, and you can then share your screen. I urge you all to keep your questions till the end of the presentation, when there'll be absolute opportunity to discuss anything that you thought you wanted to get clarification on. You can also type questions in the chat function if you need to leave the session before it finishes, or if for some other reason you need to make sure your question gets noticed. And once again, I thank you all for making the time to be with MAG and to enjoy this seminar. Thank you so much. Dr. Rob Will, over to you.
Thank you very much, Michelle. Thank you for those kind words of introduction. And thank you, everyone, for joining for this session. I'm a bit blown away by the interest. Now, I'll just get the presentation up. Now, as Michelle has mentioned, very happy to deal with questions, but I think it's probably easier if they can be at the end of my presentation. If you wish to put them in the chat function, and I can look at that first, but obviously I can also take any oral questions. Let's just close that one down. So, occupational overuse, as Michelle indicated, does cover a broad range of possible conditions. So I will talk first about broadly the clinical examples that we can include under that umbrella term. Then say a little bit about the epidemiology of probably the most common of these conditions. Talk about some clinical presentations, focus on those. Say a little bit about the neurophysiology of neuropathic pain, and then talk about the assessment of these patients, management, treatment, and finally prognosis. So we're talking largely about conditions that affect the upper extremities, though I will touch on some lower limb conditions a bit later on. And we're particularly focusing on conditions that often have their origin in the cervical spine, but extend to the shoulder and upper limb. And we know that particular activities can aggravate these conditions. And I just would like to draw attention to the fact that often we're dealing with patients who can have multiple pathologies. And so it's the doctors, the specialists' role to tease these out as to what the relative role of these are. And cervical spondylosis is certainly a very common condition that exists with many of these patients, particularly the older ones. And then, of course, associated with that is cervical nerve root involvement. We then come to conditions like lateral epicondylitis, which can occur due to injuries. And one of the important things about lateral epicondylitis is that you often get radiation of that syndrome into the forearm and hand, typically in a radial nerve distribution. And so it can be confused with neuropathic pain radiating in that distribution. So often you have these conditions, which is not just one syndrome, or it may begin with predominantly, say, a lateral epicondylitis, which may have been provoked by a work injury or by overuse, or may occur because of another condition, and but can be associated with radiation down the arm. And medial epicondylitis can be very similar.
He's going on your birthday to have the stone removed. What? He's booked in to have the stone removed on your birthday.
Sorry, someone's got their audio.
Sorry.
Can you mute that, please? Thanks. So it can be medial epicondylitis can radiate in the ulnar nerve distribution. There are then syndromes, the so-called T4 syndrome, which can be linked to localized pain around the trapezial and rhomboid muscles, and has the term myofascial pain syndrome has been used also to describe this. Typically, occupational overuse pain syndromes affect the dorsal forearm with radiation to the hand, but can of course involve the whole of the upper limb extending from the cervical spine into trapezial region, shoulder, and into the upper limb, into the hand rather. Now, just like to touch on, however, other so-called arthritic conditions could have been provoked by repetitive use or aggravated by repetitive use of the hands. So pain involving the carpometacarpal joint at the base of the thumb, or scaphotrapezial trapezoid syndromes. And occupational groups may have a higher rate of problems of these joints. I should mention de Quervains. So de Quervains tenosynovitis is a tenosynovitis over the radial border of the forearm, and it typically involves extensor pollicis longus and abductor pollicis longus tendon sheaths with inflammation. Remember that patients who get hip and knee osteoarthritis, and normally we just regard these as due to arthritis, and however, we know that lower limb arthritis is more common in particular occupational groups. And typically this used to be farmers and miners, but we might not normally regard sportsmen as having occupational induced injuries. So of course, sportsmen during the professional years obviously would be regarded as possibly having these conditions. And for example, long distance runners, marathon runners have accelerated hip and knee osteoarthritis. Carpal tunnel syndrome can of course be induced by work issues, but very commonly occurs in at all age groups, and we need to keep that in mind. So typically, for example, carpal tunnel syndrome can occur in pregnant women, then resolves following delivery. Related entrapment syndrome is Guyon's canal syndrome, which is an ulnar nerve entrapment syndrome over the distal ulna at the wrist. So let's move on and talk a little bit about the this really epidemic of occupational overuse pain, which, as Michelle touched on briefly, had its origins as repetitive strain injury. And sometimes I'll use that term because some of the more older publications are still using that term. And it began its life around 1982 in Australia, interestingly. And in fact, during the early 80s, nearly a third of all disease cases of workers' compensation in New South Wales were regarded as occupational overuse syndrome. Now, there are specific occupational groups at risk, and this is by no means a complete list. There are multiple different examples, and I'm sure all of our audience members can tell us about particular occupations that I've missed. But for example, fruit pickers, fruit sorters and packers, mushroom pickers I've come across in the last year or two, a high rate of these conditions, flower decorators, and particularly the data entry operators. Croupiers is another group. I will talk a little bit later about ultrasound sonographers or operators. Now, I'd also like to touch on the evidence for overlap between occupational overuse syndromes, complex regional pain syndromes, and fibromyalgia. And I'll direct everyone to the publication of Manius. So in this particular publication, it was a literature search that was undertaken looking at these three conditions and focusing on similarities between the conditions. To be eligible to participate in the study, they needed at least 20 subjects. So there were 59 studies on CRPS, 73 on fibromyalgia, and 7 on RSI or occupational overuse syndromes where other conditions were excluded. And one of the things that they noted in this study was that diseases showed a lot of similarities in terms of age, male-female ratio, pain characteristics, and sensory signs and symptoms. And while motor, autonomic, and trophic changes are more frequently reported in CRPS, they can occasionally be seen in fibromyalgia and RSI, or occupational overuse. Systemic symptoms are found in patients with CRPS and fibromyalgia, and in a subgroup of patients with RSI. And in all three groups, all three disorders, symptoms usually start locally, but may then spread to other body regions later. So this is very well documented, for example, in CRPS, where you can get one limb affected initially, then the ipsilateral limb affected, and then spreading to the upper or lower regions of the body, depending on where it began. And in fact, systemic spread is the requirement for a diagnosis of fibromyalgia. Disease onset is always, usually, or occasionally traumatic in origin in RSI, CRPS, and on occasions in patients with fibromyalgia. And anxiety and depression are more frequent in patients compared with controls with all these conditions, but probably not very different from patients with other pain conditions or other chronic diseases leading to chronic pain, such as patients with back injuries, rheumatoid arthritis, and the like. So the conclusions from this particular study were that apart from the obvious differences between these different entities, the similarities are conspicuous. And the common features of these three conditions may suggest that a common neurological pathway, so we're talking about a neurological disorders, is involved. We know now from extensive studies of the central nervous system that that CRPS and fibromyalgia are neurological disorders. But until patients with these symptoms and these conditions are assessed with a uniform assessment procedure, a thorough comparison between them cannot be made. So as a systematic evaluation of patients with these diagnoses may lead to a better appreciation not only of the differences between them, but the similarities of these diseases, and help to unravel the underlying mechanisms of the disorders. So I'd like to touch on sonographers. Now, I'm sure most of those in the audience will have had an ultrasound at some stage in their life, and they're aware of the procedure that's undertaken. This is quite an old study, but illustrates a lot of the issues in terms of occupational overuse and the causation, and in fact, even more importantly, the management of these patients. Sorry, stick with that. So one of the features of these patients and the analysis of the nature of their problem is that what is noticed is that the minute movements of the transducer that the sonographer has to clasp is that they have to grip it very firmly and tightly and hold it tightly against the patient's skin. And this can trigger insult to small muscle fibers of the fingers, hand, and forearm. And one of the interesting things about the analysis of individuals who have developed this condition, it's much more common in women. And it's thought that the reason for that is that to exert the required forces, women have to press harder on the transducer than men, which is probably relevant to the development of this problem. The other thing that's noticed about these patients is they have to twist and bend the wrist in often anatomically unusual postures to apply the pressure against the patient's skin to undertake the scans. Also, the elbow and shoulder has to be typically abducted away from the body while pressing down against the skin for a sustained period of time, which compromises the muscles of the shoulder, joint, neck, and back. And the other thing that's characteristic about this is that performing these muscle activities is often undertaken in a compromised posture. So in other words, the sonographer often has to lean across the patient's body and has to twist their torso and neck to both look at the monitor and look at the patient at the same time. And this leads to back and neck strain. The further factor that's relevant to the development of these conditions is the poor workplace ergonomics. So often the height of the keyboard is not at an appropriate height for the sonographer. The height and direction of the monitor may not be appropriate. The sonographer's chair height may not be appropriate. The exam table height and width may not be appropriate. There may be improper room lighting, which makes it difficult to undertake the examination and contributes significantly to forcing sonographers into compromising positions while performing exams. Sorry, someone else has got their audio on. They could turn it off. Thank you. And of course, one size never fits all. And different heights, different ages, and of course the gender, as I pointed out, these problems are much more common in women than in men, are relevant to the causation of these conditions. Now I'll just mention a couple of case summaries. So of individuals who develop significant problems. So Susan Murphy worked for 18 years as a sonographer and revealed, now these are her words, some of the brutal realities of the current profession. Now, I should point out that this, of course, this study was published in 2001, so over 20 years ago. And I believe that there have been dramatic changes in the profession since then because of the high rate of these disorders that occurred. So at that time, to quote Ms. Murphy, the practice of medicine has changed dramatically too. The focus has shifted to issues concerning reimbursement, increased productivity and minimising expenses. Many recommendations were made to improve the ergonomic situation. Instead, managers were pressured to increase the number of scanned patients. And as a result, patient volumes went up, rest breaks between exams went down, and sonographers were now increasing the time spent in positions of postural dysfunction, with little or no rest breaks available throughout the day. So Susan indicated that these injuries became so bad that she was unable to perform simple daily tasks such as laundry, cooking, and cleaning. Her fear of losing her job was compounded by the fear of her losing her ability to care for her family. So a very typical scenario of patients who can develop severe occupational overuse pain syndromes. Another woman who lost her, another sonographer who lost her career to overuse work-related injury had a testimony similar to Susan's. This woman, who asked to remain anonymous, felt compelled to share her experience for the purpose of helping other sonographers and avoid the same fate. I love being a sonographer. I'm so very sad to have lost something that I love so deeply. My physician has told me that these conditions are the permanent result of attempting to compensate for the pain, the rotator cuff tear, and the impingement that I experienced. Similar to Murphy's testimony, she reveals, we often scan 10 to 12 hours a day without breaks or lunch. And like Susan, this woman grieved not only for the loss of a job, but also the loss of valued family activities. And to quote Miss Anonymous, even the gentle tug of my grandchildren's hand was very painful. So I'll say a little bit about the mechanisms of injury in these patients. So repetitive strain injury or occupational overuse syndrome was felt by the sonographer in a variety of ways, and recall that the original insult will most likely not present noticeable symptoms, But as time passes, the following symptoms are felt. So the symptoms become more constant. The nature of the pain can change. So they develop symptoms of a neurological nature of tingling, numbness, shooting sensations, weakness, itching, burning sensations, clumsiness of the fingers, swelling, changes in muscle bulk, and pain is felt in the neck, back, arms, hands, the fingers, as well as the shoulder, elbow, and wrist joints, with reduced mobility, freezing of joints, and eventually total loss of function at the end stage of this condition. So you can see that these conditions of occupational overuse can morph into CRPS with visible changes to the limb and trophic changes in patients at the severe end of the injury spectrum. So let's move on. So we'll talk about another occupational group, and that is of musicians. So this is a more recent publication published, in fact, this year in a Polish journal. And they were looking, their particular interest was to look at the angle of trunk rotation symmetry and of lower limb loading, interestingly. So looking at lower limbs in musicians of a symphony orchestra in Poland. And what they found was the evidence of frequent dysfunctions in musicians and postural disorders. So the trunks, what they noted was that the trunk of many of these musicians, and interestingly, these were particularly in violinists and cellists, where the trunk's asymmetry in the frontal plane produced an increase in the spine's physiological curvature. So this wasn't just in professional musicians in the orchestra, but they also noted this in children and adolescents studying at music school and at students at higher music schools, so in other words, at university. And the long-term assumption of a forced, often asymmetrical position may also disturb posture and balance. And postural asymmetry may lead to severe postural disorders, including scoliosis. So it's interesting, the evidence in this particular group of musicians and how they can develop significant postural disorders, so involving the trunk. So we're not just talking about an upper limb problem. And due to the different types of musical instruments, defects in postural stability disorders may differ between the musicians. So they obviously can differ depending on whether you're a brass player or whether you're a violinist or a cellist. And it was particularly musicians playing asymmetrical instruments such as violin or cello that are particularly at risk of postural disorders. And other publications have confirmed the occurrence of musculoskeletal disorders in 80 to 90% of musicians. Well, what about dancers? So another group of people who work in our entertainment industry who can develop these disorders. So this is another recent publication, in fact, published in Journal of Sports Sciences. So what happens to dancers? So they investigated work-related musculoskeletal injuries over 15 years in professional modern dancers to determine the injury rate and pattern differences due to sex and professional, should say gender, and professional experience. So injuries were coded to allow analyses by tissue type, body region, severity, setting, mechanism, action, causation, and repertory style. And injury prevalence was defined as average risk of injury per dancer, and injury incidence was calculated per 1,000 hours of exposure. And interestingly, they found differences between females and males. So females were 15 times more likely to sustain bone injuries. I mean, that's a massive difference compared with males, who are 8 to 15 times more likely to sustain muscle and tendon injuries or lacerations, contusions. And females were more likely to sustain severe injury, resulting in more lost work days and missed performances. So very significant difference, so P less than 0.001. in both sexes, more time loss injuries occurred in performance. So performance led to more injuries, were traumatic in nature, with an action causation of particularly jumping, stopping, and releve. And dancers of moderate professional experience were more likely to sustain injuries. So identifying context-specific activities and repertory style relationships to injury can provide insight into casting and rehearsal scheduling. So in other words, identifying the types of performance that are more likely to lead to injury, affecting particular groups can help to prevent this. Clearly understanding the nature of the workplace and the people in that workplace that are particular at risk can lead to a reduction in the rate and the severity of these injuries. Now, I won't say a lot about the military, but just to point out that occupational overuse injuries is exceptionally high in the military. And this was a publication from the UK. And it was actually a publication from an orthopedic textbook, which is quoted there. And so it just illustrates that there's a range of lower limb injuries that are common in this particular occupational group. And the authors, rather tongue-in-cheek, made the comment that, of course, the military doesn't take into account the different heights and weights of their recruits. They all have to march at the same rate. And of course, if you're short with short legs, they have to move a lot more quickly than if you're tall with long legs. You would have thought by now, 2022, the military might have picked this up, but no. Some injuries are very common, so particular patellar tendinopathies and Achilles tendinopathies, but also you can develop other tendinopathies in these military recruits, including gluteal, hamstring, and common peroneal tendinopathies. So-called shin splints or medial tibial stress fractures are very common and related to just particularly marching, carrying heavy backpacks. The other synonyms for this are periostitis or inflammation of the periosteum or periosteal inflammation. And of course, you can get compartment syndromes, which can be induced by a repetitive marching. There's also a syndrome of popliteal artery entrapment, which can occur for the same reason, and superficial peroneal nerve entrapment, which can cause neurological problems in the lateral calf and foot, is also relatively common. So just saying a little bit about the neurophysiology of neuropathic pain. So all the evidence from all the academic literature now is pointing to these pain syndromes producing, apart from the ones which I mentioned just on the military recruits and some of the others, but the large bulk of occupational overuse in many of these occupational groups, all the evidence points to this being neuropathic pain. So what do we know about neuropathic pain? So this pain arising directly from a lesion or disease that affects the somatosensory system. It's a common clinical problem, and it typically causes intense distress. And a lot of the studies of this have occurred in patients, particularly with peripheral neuropathies. But when you examine these patients, they have sensory abnormalities and can experience pain of diverse types, some spontaneous, but others provoked. And spontaneous pain typically manifests as ongoing burning pain or paroxysmal electric shock-like sensation. And provoked pain can occur with various stimuli, even just gently brushing the limb. Now that's typically occurs with CRPS, of course. And recent clinical and neurophysiological studies suggest that the various pain types arise through distinct pathophysiological mechanisms. And ongoing burning pain primarily reflects spontaneous hyperactivity, so people who report continuous burning pain. So it's spontaneous hyperactivity in nociceptive fiber pathways originating from irritable nociceptors, regenerating nerve sprouts, or denervated central neurons. So they're the particular neurological structures that can cause spontaneous pain. Paroxysmal sensations, however, are caused by several mechanisms. For example, electric shock-like sensations, probably arising from high-frequency bursts generated in demyelinated, non-nociceptive A-beta fibers. And most human and animal findings suggest that brush evoked, so in other words, what I mentioned before, using gentle brush, provokes this sensation of allodynia. So allodynia is simply light, gently touching someone on their limb. That provoking pain is due to a particular sensitization of particular nerve fibers, and that's the A-beta fibers projecting onto previously sensitized nociceptive neurons in the dorsal horn. So that's the posterior or rear part of the spinal cord, usually at the entry site of the nerve roots, with additional contributions from plastic changes in the brainstem and thalamus. So it's been demonstrated in many of these studies that there are changes not only in the spinal cord at the site of entry of the nerve fibers, but also higher up in the neuraxis, so in the brainstem and in the brain. We know that there are diffuse changes now demonstrated in the brain of patients with CRPS and fibromyalgia, for example. This is covered in this publication, this reference that I've indicated below. So what about assessment of these patients? So assessment is largely that of musculoskeletal. So the patient needs to have a musculoskeletal assessment where you're considering occupational overuse and a neurological assessment. So in terms of the musculoskeletal assessment, we need to look for any changes of the joints. So as I mentioned at the beginning, it's important to look at what the various clinical issues are that that patient has. So we might not, of course, just be dealing with occupational overuse. And this, of course, gets more common as the patient gets older and they have more musculoskeletal problems and or more neurological problems. So, for example, when we assess their joints, we might see features of joint asymmetry, joint tenderness or swelling. The swelling might be diffuse. For example, if we're seeing someone with CRPS, typically we don't see that diffuse swelling in someone with occupational overuse, except at the very severe end of the spectrum. It's important that we assess patients for joint synovitis, and that's where our rheumatologists come in, because they're all trained to assess for joint synovitis. And so typically synovitis just simply means inflammation of the joint. So we look for changes of altered colour, temperature or tenderness over the joint. And range of joint movement, of course, is very important, and that's also part of the impairment assessment of these patients. Of course, we have to assess their spine for any obvious deformity and spinal range of movement. So we need to have measures of cervical spinal mobility, lumbar spinal mobility, and thoracic spine. Thoracic spine, we tend to assess indirectly by chest expansion. And then, of course, it's important to look for tenderness, and fibromyalgia was classically regarded as a condition of multiple tender points, but in fact it has been expanded to a lot of other features now. And then we come to the neurological assessment of these patients. So we initially assess, of course, the patient's gait, how they present, their balance, of course, any apparent psychological issues, such as verbalization and such. But we also need to look for muscle atrophy, muscle weakness, reflex asymmetry, and plantar reflexes. And then sensory assessment involves, for example, neural stretch. So patients typically with occupational overuse or significant occupational overuse can have positive neural stretch signs and altered pinpricks response, allodynia, as I mentioned, and altered temperature sensation. I will mention one particular technique that's being used widely in the research sphere at present, and that's quantitative sensory testing. And it's a psychophysiological tool that measures perception of mechanical, thermal, and painful stimuli delivered at a controlled intensity to determine perceptive threshold for each sensation and stimuli that's applied. So you can apply mechanical stimuli with graded responses using these so-called von Frey hairs, or you can deliver pinprick sensation using weighted needles, and can measure vibration sensitivity and thermal perception using thermodes to deliver either hot or cold sensations. And QST is typically used to diagnose small fiber neuropathy in diabetics, but it's also suitable for the assessment of patients with occupational overuse, CRPS, and fibromyalgia, and patients who have allodynia and hyperalgesia syndromes, and also to then assess the response to treatment. However, QST cannot conclusively document neuropathic pain because conditions typically associated with non-neuropathic pain, such as rheumatoid arthritis, may produce abnormalities. So clearly it's important to assess patients for other confounders like that when they're assessed. But it is a useful tool that's being used increasingly in assessing patients with these conditions. So what else do we do? So I won't go into imaging in a great deal, but as I'm sure many in this audience know, many of these patients have multiple forms of imaging, which can include plain X-rays. Ultrasound is clearly important in patients for the assessment who have occupational overuse to rule out tendinitis, bursitis, carpal tunnel syndrome. CT scanning may be relevant, but of course, many of these patients, particularly older patients, if you assess their spine, have false positives and false negatives on CT scanning and MRIs. So many patients can have, for example, evidence of nerve root impingement or spinal stenoses, and that's not relevant to their problem. And that's even particularly the case where isotopic bone scanning is used, and infrared thermography was used a good deal, but it does have a high problem of problems of specificity. And then, of course, we use EMG and nerve conduction testing, particularly for assessing for entrapment neuropathies and peripheral neuropathy. So what about management of these patients? So clearly, it's important to do an assessment of not only the patient's work environment, but it's also essential to assess the patient. And so now this is obviously by no means complete, and I'm sure there are a lot of other issues here that I'm sure many members of the audience could add to this list, but the evaluation of the work environment is clearly essential, and looking at the factors that influence the development of the pain syndrome. And I used the example of sonographers previously, so clearly it's important to look carefully at their work environment and factors that may be relevant to the development of pain that they might be experiencing, and looking at ways of minimizing that at a much earlier stage before it becomes chronic and established. So clearly factors of the work type, the rate at which patients have that the employee has to work, and breaks that are introduced into their work schedule, and clearly this typo there is not patient, it's the employee skills and training. So we saw that, for example, more experienced dancers are less likely to develop these same injuries that less experienced dancers can experience. And I imagine the same could be true of sonographers. So it's important to look at the training and skills of the employee, and looking at clearly modifications to their work rate and their work environment that can lessen the likelihood of occupational overuse occurring. And then we come to the patient assessment. I can't minimize the importance of correct diagnosis. So occupational overuse syndromes are a diagnosis exclusion. So it's important to look at all the other conditions that might mimic these particular conditions. And that can, firstly, the examination of the patient is the most important thing to make the correct diagnosis, and then to use, and as clinicians know, the history can is often 80% of the diagnosis. Examination probably another 10% or 15%, and investigation is usually a fairly minimal part of making a correct diagnosis. But of course, investigations nevertheless have a place. So we need to look at the likelihood of these conditions of occupational overuse, but as I mentioned, CRPS or fibromyalgia. And just to complicate matters, of course, these conditions can overlap in the same patient. And as I mentioned, the relevance of other diagnoses, so musculoskeletal, neurological, and of course, psychological. And of course, we require the input from our professional colleagues, so from physiotherapists, occupational therapists, exercise physiologists, not least, of course, with exercise physiologists to plan exercise programs and modifications of the patient's work and work schedule. But also, it's been found, for example, in sonographers, increasing muscle strength has great benefits in reducing the likelihood of these conditions developing. Psychological input is important, and of course, we often need the input of psychiatrists. What about therapeutics? Well, unfortunately, we missed the boat by the time we get to reaching for our script pad, because these conditions are established at that point. And certainly once you have established occupational overuse and patient has chronic pain, it's not going to go away quickly. And in my experience, in many of these patients, never disappears. There are a number of therapeutics available. They all have their problems and, as I said, a limited effectiveness. So we do use pregabalin. There's a problem with that in that it's addictive and has quite a lot of side effects. In addition to that, not least of which is weight gain. Duloxetine is an SNRI, so one of the antidepressant medications, but it's been found to help with neuropathic pain and can be quite effective, for example, in fibromyalgia. We also use amitriptyline and nortriptyline, which are earlier, older tricyclics, which can work in low doses. Typically can help fibromyalgia, don't normally do anything for occupational overuse. Analgesics, we obviously have to be careful using them, particularly the stronger ones, because of the problems of dependence and addiction. And unless there is a very good reason to operate on these patients, surgery should be avoided, because surgery almost always makes patients worse who have occupational overuse as the cause of their pain problems. So I often see many patients who've had their necks operated on or their rotator cuffs or shoulders because of these pain syndromes. And almost invariably, patients with neuropathic pain, it gets worse if you operate on them. And of course, psychological factors are important to deal with the psychological factors. And clearly, if we get to the stage of someone no longer being able to work, then that causes a lot of issues for the patient and their family. As I indicated with sonographers who can no longer work because of their problem. So I think on that note, there's quite an extensive reference list, which I'm happy to make available to those in the audience who want to look into this in more detail. But that's it. So very happy to take questions. Let me just have a quick look at the chat box and see what's there. So I don't have any, so there's no questions in the chat box. Let's just close that down. And so very happy to deal with any questions. If anyone has anything they'd like to ask me. So I think just to, if we could just unmute one at a time.
Yep, so thank you, Professor Will, for a very informative and interesting seminar. If anyone has any questions, please do unmute yourself and come forward.
Yes, look, I'm happy to, if you could just request to Michelle if you want the presentation, but could I ask, don't, it's sort of professional in confidence, so don't spread it around unless you get Michelle's okay to pass it on to one of your colleagues.
Yeah, I think we have a question from S. Jane. While I heard about the other assessments, what does neural stretching entail? It's in the chat box.
Yes, so there are a series of different stretching maneuvers you can undertake in patients when you're examining them. And it just helps to reinforce the presence of neuropathic pain, irrespective of the cause of it. Clearly, you've got to establish what the possible or likely cause of that patient's neuropathic pain is. And of course, common conditions that can masquerade as occupational overuse conditions like radiculopathies, cervical radiculopathies, or neural entrapment syndrome. So you have to consider the possibility of these conditions that could produce similar clinical findings. Let's just go back to the chat box. I think we've got a bit more in there. So a question from Chantel. If the pain onset is identified early on, how long does any workplace aggravation take to cease? Well, that's a very good question, Chantel. And I guess it's always, well, how long's a bit of string? Generally speaking, I think the important thing is for the employer to identify any of their employees who have symptomatology that might suggest overuse and intervene at a much earlier stage. Typically, if patients' pain is disappearing when they go home overnight and it doesn't come back for a week and comes back, perhaps if just their load increases or the duration of work increases, then that indicates an earlier stage of the condition. But if you get the patient where their pain, well, that for example, their pain might persist during the week, but goes away at the weekend, and as soon as they go back to work on Monday, it tells you their pain is becoming a lot more persistent and chronic. So really you want to get to them before they get to that stage where they just have intermittent pain that's coming and going and intervening. If you get someone who perhaps their pain goes away over a long weekend, but comes back the following week, it tells you it's just advancing, it's just getting worse and more progressive. And of course, if they then take holidays and they are on holidays for a couple of weeks and their pain doesn't go away, but it improves, it tells you it's becoming more established and more chronic. So there's this scenario of just worsening pain that obviously needs intervention at an earlier stage. Okay, I think we've dealt with that one. Okay, so happy to deal with any other questions if we have any.
Yep, so final round of questions. If anyone has any questions, please do come forward or put your questions in the chat box. Yep, so we got another one from Chantel as well.
Sure. Look, I think it's important clearly to have good relationships with the psychologist or psychiatrist who's dealing with the patient. And I would have to say I've not come across too many patients where there's been apparent lingering. I've had a few, but look, I agree one needs to always consider whether there are any red flags that might suggest that. And largely as a medico, we're often reliant on our allied health colleagues to alert us if there's anything unusual happening with the patient's behaviour and inconsistency of their of the way in which they present to different practitioners.
Yep, so I think that would be the final question. So I think we should wrap up. Does anyone else have any other questions? Oh, yep, another one just came through.
Okay. I'm currently wearing a wrist brace for overuse of the keyboard and mouse. Okay. So again, look, just in first principles, you need to see a doctor, get an assessment, and make sure that there isn't anything else that's contributing to your wrist pain. But clearly, it's a matter of getting an assessment of whether it could be a joint problem, tendon problem. So it requires the appropriate assessment and investigation. And if it does seem to be a joint problem or a tendon problem, then cortisone injections can be quite useful, but simply wearing splints, resting splints, can be helpful as well for many people.
Yep. So I think that would be the final question. So thank you so much, everyone who attended this seminar, and thank you, Professor Will, for a very informative seminar. For those that requested for PowerPoint slides, Professor Will you be okay if I distribute them to just like individuals who requested it, or?
Yeah, if you could do that and just keep a note of who they are, and just ask those who received the slides that that you don't just forward them on without getting Michelle's okay first.
Yep, that's all good. So I will, okay, all good. So I'll just send a list of who they are to you, and to see if you're okay with that.
Okay, thanks, Michelle.
Okay. Thank you everyone for attending, and thank you, Professor Will. I think our seminar will be done for today. So thank you.
Okay, thanks, Michelle. I'll sign off. Okay.